We have a very interesting IC, that is OCT angiography, navigating teenage tantrums. What you know, OCT angiography is one of the most recent investigations or imaging tool in retina at the moment, and a lot of work is going on. That is one of the reasons why we wanted to inform the audience how to interpret and what are the different conditions where we can do an OCT angiography to get maximum information. We have 5 speakers, and we have Dr. Nihal Adil Hussain. She'll be talking on OCT biomarkers in DME. She is a board member at Egyptian Society and also director at Egyptian Hospital. And she'll be talking on OCT biomarkers in DME. I'll be talking about how to interpret OCT, and Ritesh will be talking about artifacts. We have Dr. Puneet Gupta, Anand Rajendran, Ajay Purohit, and Dr. Lalit Verma, who will be dealing with different topics in OCT angiography. So I'll request Dr. Nihal Adil Hussain to give her talk on OCT biomarkers in DME.
Good morning, everybody. Thank you, Mr. Chairman. Thank you for the introduction. It's always a great pleasure for me.
Can you change the slide, please? Slide us pe kar dijiyega.
It's always a great pleasure for me and honor to join the All Indian Society meetings in India. Thanks a lot for all the scientific committee, especially Professor Namrata for her kind invitation and general hospitality. To talk about OCT biomarkers in OCT, this gives me the chance of introduction of how the technology in OCT, as we all know from the time domain to the swept source OCT with its high resolution, gave us the advent of giving the real histological picture of the retina, and this is the recent high definition, high resolution picture that we all see in the OCT. We're giving the details of all structure by structure and line by line, as if a histological section, optical histological section in the macular area, and to focus on the outer retinal layer, which is the very important layers in giving the visual prognosis and the visual outcome of medication for the patient, defining the external limiting membrane, ISOS junction, RPE Brooks membrane complex, and giving the zones of the myoid, ellipsoid, and the interdigitation zones. These are very, very important to document upon in our OCT reports, and this gives any changes in the pathological change, gives the biomarkers for our extent of the severity of the disease. This is, as we all know, the histology of the macular area, and to overlap this histology on the morphology and the reflectivity of the tissues in the OCT, which gives the integrity of the system, the 10 layers of the retina, starting from the nerve fiber layer, the interdigitations and the molar cell fibers, the outer retinal layer, and the reflectivity of the outer retinal layer, which is corresponding and the components of the nuclear of the photoreceptor layer, and up to the RPE layer, which is very, very important, as we all know, for intactness and the light stimulation and the light response. These are the 12 points that we should talk about in any of the OCT picture of the biomarkers, and especially my talk will include in diabetic macular edema, starting with the disorganization of the retinal layer, inner retinal layer, which is the first point that I should like to comment upon, the hyperreflectivity in the retinal and the choroidal zones, intraretinal cyst and the sizes, which is differentiating the severity of the lesions, up to the choroidal vascularity and the choroidal thickness. These are examples of the biomarkers which are the in vivo signs that we should see in an OCT picture reflecting the severity and the response of treatment. The disorganization in the inner retinal layer is very, very important because it reflects the intactness of the inner retinal layer with the ischemic changes in cases like diabetic macular edema, the hyperreflective zones, and these are degenerated ganglion cell layers and can be differentiated from the high reflective foci of the hard exudation, which gives a posterior backshadowing in this condition. And these high reflective lesions with the high condensation in the intraretinal cysts, denoting the chronicity of the macular edema. And in this case, to see the hyperreflective shadow in the outer retinal layer with, disturbing the complexes of the AIOS junction and the Brooks membrane choroidal complex, choriocapillaris complex with the high reflectivity, denotes that there's, even after the treatment and the macular edema, cystic macular edema response, there is a visual, bad visual prognosis due to this disruption of the outer retinal layer. And here also is a drill sign, which is the disorganization in the inner retinal layer, denoting the visual dysfunction. And this carries a poor prognosis if it's more than 500 microns, according to the classification. Intraretinal cystic spaces and the shape of the spaces, the reflectivity of the intraretinal cyst itself, and the size of these cystic spaces will differentiate from classifying the condition from small, large, and giant spaces. The intactness of the molar fiber layer, which is the communication from the inner and the outer retinal segments, and this communication is very, very important for the visual prognosis. And if seen disrupted, and also with the disorganization of the inner retinal layer with the cystic spaces denoting ischemic changes. And here is a large intraretinal cystic space with marked thinning of the overlapping inner retinal layer, and also there is disruption and high reflectivity denoting RPE changes in the subfoveal space. All these criteria will denote bad prognosis with treatment and post-treatment. As well as if we'll see the vitreoretinal interface with RPE, with the epiretinal membrane, shadow of epiretinal membrane, and intraretinal cystic spaces with multiple intraretinal cystic spaces, and also there is disruption of the outer retinal layer. This all carries bad prognosis for treatment. And if this moth-eaten appearance with the markedly thin inner retinal layer, and here are cystic spaces denoting ischemic changes, and even after treatment with intravitreal VEGF, improved retinal thickness, but left with an atrophic, markedly thin fovea, and no visual improvement actually in that patient. If there is a subfoveal neurosensory detachment, this carries a good prognosis with the treatment. But here, in this case, there's high reflective deposits in the intraretinal spaces of high exudation, as we can see corresponding in the color photography. And this, of course, carries worse prognosis than the upper example, but here the reflectivity and the thickness of the vascular index of the choroid is good, so it's better prognosis in the upper photo than in the lower photo. If there is epiretinal membrane and intracystic edema, even with subneurosensory detachment, but with the treatment, the macular thickness improved and macular edema regressed, but there is still a taut posterior hyaloid with the epiretinal membrane, leading to slight traction on the inner retinal layer. Choroidal vasculature is very, very important in the prognostic and the response of intravitreal injection of such patient, and the vitality of the macular area, as we all know. And to measure the choroidal thickness in this case is very important. And on contrary, this is a thin choroid with markedly thin loss of the foveal contour in a in an ischemic macular ischemia. This is a comparative study in the macular edema and the thickness of the macular area compared to the choroidal thickness. And of course, there is marked improvement with intra-VEGF in cases with thickened choroid. This means the vitality of the structures, especially the outer retinal layer. And in these photos, both of these photos, we can see the integrity of the outer retinal layer, external limiting membrane, and the Brooks membrane, RPE, they are intact, so it carries a better prognosis, though the thickness of the macular area is about 450 microns. Of course, the addition of the technology of the OCT angiogram, this gives a better visualization and more accurate assessment of the vasculature, and even, of course, of the segmentation on layers of the superficial and deep retinal layer with the choriocapillaris. So it compares the three layers of the vasculature in the macular area, not only the overall vascular component of the macular area. And here is a case, even if we are not seeing any macular edema in the B scan, but there is obvious irregularity in the foveal avascular zone with fragmentation of the network, capillary network, in both the deep and superficial retinal layers, which is ischemic maculopathy, though the patient might be missed in cases or even with fluorescein angiography, it won't be that clear due to if there is a slight diffusion of the dye in the late phase or minimal cataract, for example. And this is a more severe case with obviously very enlarged, irregular, complete loss of the capillary flow in the macular area with marked thinning in the B scan, which is a severe case of ischemic maculopathy. So these are the biomarkers which might see and should comment upon in cases of diabetic macular edema. As we all know, since the diabetic retinopathy is one of the most leading causes of blindness in the middle-aged population, so biomarkers, and to look for biomarkers in imaging, which provides in vivo assessment of the health of the retina, choroid, as well as to properly, accurately denote the severity of the condition, response to therapy, and the visual outcome of the patient, which is important for me as a doctor and to inform the patient before any treatment protocol. I will have that chance to, of course, invite you all to our annual meeting of the Egyptian Society. It will be on the 7th to 8th of May in Cairo. Looking forward for all to join us, and thank you very much for your invitation and attendance.
Any questions from the audience?
Yeah, Dr. Hassan, just one point. Any of the biomarkers that you look at for deciding what kind of anti-VEGF or treatment modality you would be using?
Yes, for me, if I will see subfoveal edema and subfoveal neurosensory detachment and good vasculature of the choroid, I will go more for steroid injections. Even if, like triamcinolone alone, it will respond dramatically better than giving anti-VEGF. If there is epiretinal membrane, I will see according to the stiffness of this epiretinal membrane and the tangential traction on the inner retinal layer, if I will balance, if the traction is more, or the cystic edema and the thickness of the edema with the preservation of the intraretinal septa is very important, I will go first for injections, rather than going for vitreoretinal surgery, as of course vitreoretinal surgeons will prefer. But I will prefer to give the chance of injection rather than going firstly for vitreoretinal surgery. Choroidal vasculature is very, very important in these cases because, as I said before, and I'm stressing upon, this gives the vitality of the tissue and the response, because being vital and thickness is good, it means that it will respond much more to the intravitreal injection.
Thank you so much. Thank you.
Dear.
So we'll start off with our IC on OCT angiography, and the first speaker would be the chairman of the session, Dr. Avninder Gupta, who is a senior vitreoretinal surgeon from Faridabad and Delhi, and he would be talking about introduction to OCT angiography and kind of interpretation. How do you go step by step on OCT angio?
Thank you, Ritesh. We'll start our IC, and basically first we'll learn what is OCT angiography and how to interpret it. OCTA was first introduced in 2014, It is a new armamentarium in retinal imaging, fast and non-invasive, dye-free angiography with high-definition OCT in one machine. Prior to Octa, FA and ICG were the mainstay modalities to detect any abnormalities in retinovascular visualization. Fluorescein angiography and ICGA generated two-dimensional in-force view of the retinal vasculature, but with advent of Octa, we are able to demarcate different layer of retina, that is deep superficial layers of the retina and the capillary plexus. The principle involved here is angioplex detects motion of scattering particles. These are RBCs. Within sequential OCT B scan performed repeatedly at the same location of the eye. Each cluster is acquired in the same position on the retina. Each cluster generates one blood flow scan, and then you get this kind of an angioplex details where you can see different capillaries and blood vessels in the retina. I will be talking mostly about Zeiss Cirrus 6000 because I have that machine and I don't have any financial interest into it. Zeiss uses OMAC microangiography complex. OMAG is an imaging technique which uses the complete complex OCT data signal, including both amplitude and phase. This is the only machine which has phase and amplitude, so the pictures what you get are much better. In OCT, what Dr. Nadal Hussain has told us, you see the cross-section of the retina. Like if you cut and cake like this, you will see the cross-section of the retina and then you can demarcate what are the layers of the retina. But in Octa, what you see is an in-force image, like what you are seeing, and then you are turning off the pages of the retina one by one. So if you see this video, this we call as a segmentation line, and you will come across this segmentation line again and again. The moment this segmentation you can see different phases here. This is the segmentation line. Once it reaches the choroid RP, you can start seeing the lesion at this level. So what you are doing in Octa is you are cutting horizontal planes of the retina like this. What you are cutting, not cake vertically, you are cutting the retina horizontally. So like turning the page of the retina, you see superficial plexus, you see deep plexus, avascular zone, you see RP, choroid, and you see an in-force image of the retina. So this is very important. Like if you see, these are the segmentation line. As the line moves, you can see now the choroid and different layers of retina. You can demarcate and you can find the pathology in the retina. This is a small video how OCT angiography pictures are collated. This is a non-invasive dye-free angiography with single scan simplicity. Motion of red blood cells is detected by sequential OCTs performed repeatedly at the same location up to 4 times. Based on the property of the light reflected from RBC, motion is detected and vessels with blood flow are identified. Real-time tracking of eye movement with FASTAC results in motion artifact-free images. Immediately recovers from eye movements and blinks. Angioplex is powered by OMAG algorithms, and then you get full advantage of amplitude phase from OCT, and you can see this is a superficial layer which is marked as red. The deep retinal layer is marked as green. The avascular zone is marked as blue. These are the color codings once you read the maps or the reports in the retina. This is the report how it comes, and there are 3 pictures here at different slab. This is the superficial layer, this is the NFOS images, and this is the B scan pictures, and these red dots are flow in the blood vessels. So we have two types of OCT angio. One is spectral domain and one is swept source. In spectral domain OCT, the wavelength is 840 nanometers, and a spectrometer is used as a detector, while in swept source OCTA, light source is a diode laser with 1050 nanometers, and single photodiode is used as a photodetector. The difference between swept source is fast. It can penetrate more into the retina, so you can get good images of the choroid. But the resolution is higher in spectral domain OCT. Another disadvantage of swept source OCT, the cost is double as compared to a spectral domain OCT. Coming to the interpretation of the octa images, there are three images here. One is this ENFOS image. This is the structural image, and these are the B-scan images with a flow overlay where you can see what is the flow in the blood vessels. The area of the the area what you want to image is first detected, and then you go ahead and look for the octa images. Look at the segmentation line. This is very important because the lesion, where the lesion is, whether it's in the choroid or is in the retina, the segmentation line should be at that plane. Look at the B-scan with flow overlay. This red thing, what you see here, these are the flow overlay. This tells what is the flow in this lesion. Like lesions like PCV, where the flow is very minimal, you will not get any flow overlay. And these are the structural images or an infrared images, INFAS images of the retina, how you see the retina. After you have detected, depending on the type of disease what you have, you can design what type of scan you want. If you want to see a macular lesion that is with high resolution, then you should go for a 3x3 and or 6x6 images. If you want to see, like in this patient, I want to see a CNVM, so I go for a 3x3 or 6x6 images. The moment I want to see areas of capillary non-perfusion, I'll go for a wider scan, that is 8x8 montage, that gives somewhere around 12x12, or you can go with 12x12 areas. The advantages you can see here in 12x12, you can see a lot of CNP areas. You can go beyond the arcades and see the areas of capillary non-perfusion or disease pathology in a wider area. But more the scan area, more the time it takes. And the other problem is more artifacts you will get once you have more of the scan area. Look at the INFAS images, and these are the various interfaces or the layers what you detect on octa images, superficial retina, deep retina, each of which I'll be discussing in detail in coming slides. So superficial retina slab includes hilum, ganglion cell, and inner plexiform layer. In this layer, you see superficial capillary plexus, and you can see the FSZ here. This is normal here. But many times in diabetic branch vein occlusions, you can see irregular FSZ that can explain you why the vision is less in many of the patients. Although you might not have good edema, but you will have this kind of capillary dropouts explaining why the vision is less. Deep capillary plexus extends from inner nuclear layer. The outer plexiform layer includes intermediate and deep capillary plexus. Octa is the only clinically available imaging modality that can visualize these two capillary plexus. One is deep capillary plexus and intermediate capillary plexus. Intermediate capillary plexus can only be defined in machines with Heidelberg. Other Topcon machines, Zeiss machines cannot diagnose intermediate capillary plexus. Outer retinal slab extends from the outer plexiform layer, the outer nuclear layer. This slab is avascular, so any vasculature in this layer denotes a pathology like MNB. Choriocapillary slab is defined as 20 micron slab below the retinal pigment epithelium. Much like the avascular slab, the choriocapillary slab should be evaluated in AMD and other pathologies associated with MNV. Here, what you can see here, there is in choriocapillary, you can see a nice CNVM complex here in the choriocapillaries. In this image, what you can see here, this is an pigment epithelial detachment, and you can see that segmentation line we have used an RP fit. And segmentation line automatically goes and marks the pigment epithelial detachment, and this takes care of projection artifacts. And here what you can see here at this, there is a polyp. This is one of the patient you can see here has a subretinal hemorrhage. There is an CSR like a serous detachment at the posterior pole. Once we do an fluorescein angiography, you can see a leak here, and there is an polyp-like thing within the pigment epithelial detachment which leaks. See, these images are fluorescein angiography images. If you go on to see an octa images of this patient, how much wealth of information you will get. But you will have to do a proper segmentation. You can see here the pigment epithelial detachment. It's just looking like a kidney shape, and there is a notch. So if you have a notch PD, the diagnosis is clear that is an occult CNVM. Here, if you do a segmentation here, you can see an BVN, branching vascular network, that confirms the diagnosis, yes, it's an PCV lesion. And if I go for an RP fit, you can see here there is a polyp here. So we get a wealth of diagnosis, but your segmentation should be proper to come to a diagnosis. ORCC slab is combination of outer retinal choriocapillaries. It was first described by Rosenfield et al. The slab spans from outer plexiform layer, the outer nuclear layer. The choriocapillaries can be used to screening slab of type 1, type 2, and type 3 CNVs. You can see this is ORCC slab. You can see a nice CNV complex here. Another patient, you can see a very good CNV complex in these patients. Choroidal slab displays a slab which is 50 micron slice posterior to the choriocapillaries. Differences in wavelength and light source leads to variable detection of choroidal vasculature. And if you use a wide scan, you can see whether the vessels are pachyvessels or normal vessels, and any pathology in the choroid can be detected by this. Again and again, I am stressing the importance of segmentation line. Many a times, if you don't do a proper segmentation, you will not get a proper information on octa. Like in this patient, you have a lot of projection artifacts, and I have done a manual segmentation. On manual segmentation, you can see here on structural OCT, there is a pigment epithelial detachment. On this margins, you can see here, there is an BVN. Here again, I have done a segmentation in a case of pigment epithelial detachment with subretinal hemorrhage. And once I do a segmentation, you can see here, I have done a segmentation, it's passing in between the sub-RP space. And you can see here, there are multiple polyps here, giving us a diagnosis, yes, it's in PCV. And many a times, I can tell you I have left fluorescein angiography in my macular patients. I only do OCT to come to an OCTA to come to an diagnosis. B-scan overlay is a two-dimensional projection of three-dimensional structure of the retina. In-face image should be therefore always be interpreted in context of the corresponding B-scan. Like this, you have a membrane here, so to see the flow here, you have to see these green dots here, which are the choroidal vasculature. So you know what you are seeing is corresponding to the blood flow. So you can correlate, yes, you are looking at the right structural deformity. In-face, many a times with like in this patient, you are not able to detect an NVD or NVE. So I look at an in-face image here, you can see an fibrovascular proliferation. So all three pictures in an OCTA should be interpreted. You can also compare the previous disease pattern with a new disease pattern. You can see here, this is an CNV, and we have done, patient was on anti-VEGF therapy, there was a slight fluid on B scan. And over it, I gave a gap of 3 months, and you can see the CNV has reduced, it has increased, and the fluid has increased. So this gives us an information that you should continue with anti-VEGF therapy in this patient. This is a very interesting patient. You can see a CNV here. This was on anti-VEGF therapy for 2 years down the line. And after 2 years, you can, this on 6 weekly therapy. And after 2 years, you can see here the MNV or the CNV has disappeared. So you get wealth of information on OCTA. All 3 images, and fast octa images with structural images and B scan with flow overlay should be assessed for the correct diagnosis. In doubt, always sit in the machine for correct segmentation and B scan overlays. It is evolving technology with lot to learn every year. Thank you very much for.
Thank you, Dr. Gupta, for such a comprehensive talk on basics of OCT angiography and the slabs and importance of segmentation and overlays. Any questions from the audience? Yeah, please.
So world over, Anand, what's your experience with macular diseases? With peripheral diseases, still OCTA is not the treatment of choice, but with macular diseases, what is your line of treatment, whether you go only for OCTA or you combine OCTA with fluorescein angiography?
Yeah, I think in this day and age, the Octa acquisition, as you also demonstrated, with the higher end spectral domain as well as the new generation swept source is so fast, it doesn't give you a lot of downtime. So when the patient is sitting along with structural OCT, along with autofluorescence, you can get an Octa very fast with, as you mentioned, any kind of macular disease. There's always going to be bang for that buck. And as I'll also show in my presentation, not just is it macular distortion, but also that macular FAZ enlargement is also seen. So you're actually also picking up any progressive macular ischemia that may be developing in the course of your disease. Sometimes that can also tell you whether there will be, visual acuity improvement. So sometimes underlying macular ischemia is also picked up, yeah. Absolutely. It can actually empowers us to even pick up preclinical diabetic retinopathy changes, and I'll be referring to that.
With this, we'll go on to our next talk, which is very important. Ritesh will be talking about artifacts. I have mentioned in my talks about artifacts, what are the problems with artifacts, and Ritesh will be highlighting, because if you, these were the normal octa pictures, but if you have a lot of changes in the retina, the contour becomes different, and then you get a lot of artifacts. So you should be able to interpret what are the artifacts in the retina and how to diagnose these diseases in presence of artifacts. Dr. Ritesh Narula is a senior consultant at LV Prasad Eye Institute, and he's doing a lot of work on imaging, and he's one of the centers which is in collaboration with Dr. Srinivas Sadda, and he has one of the reading centers. So he'll giving us a lot of information about imaging, and you will come to know how elucid his presentation is. Dr. Ritesh.
Thank you, Dr.
Thank you, Dr. Gupta, for those kind words. I'll be talking about interpreting OCT-A findings in setting of artifacts. I'll start off with this small slide, which actually also highlights our session, which talks about OCT angio as teenage tantrums. We took this IC, has been taking this IC for a few years, and initially we started off as a toddler, wherein it was just starting to take its steps. From here, it is becoming from a toy to a tool for us, as we have been discussing after the previous talk, how useful a tool it is becoming and no longer a toy. But in this phase of becoming from toy to tool, it is still showing some of his tantrums, and these tantrums we have to understand and try to manage those. This is my talk going to be focusing on. So as we said, it's a tool in evolution. It is a beautiful tool. We are learning a lot as we are doing more and more OCT angiographies. It gives us beautiful non-invasive images at high resolution, depth resolved, and no other tool can give us such wealth of information. Only thing is we need to tackle it the way it is presented and correctly interpret it. Now, artifacts is a big problem which we see in OCT angiography. Papers have reported between 70 to 100% prevalence of artifacts on OCT angio. So I would start with a disclaimer. All OCT angiography to certain extent have some bit of artifacts. You have to interpret and understand them carefully before reporting your patients. The artifacts can happen from different sources. You can have patient-related artifacts. You can have because of some device limitation which is causing artifacts. Sometimes we may introduce artifacts by too much of over-processing these images by using a lot of algorithms on it. Nowadays, we extract these images out from it. We use further softwares on it. So we itself may be introducing a lot of artifacts. Eventually, even Dr. Gupta's slide, you realize there's a lot of mathematics happening when these images are being interpreted. And the way you do your maths can also lead to errors. So we need to correlate all OCT angiographies to a certain extent with clinical context, fundus photograph. I'm not saying a very big believer in always doing a dye-based, but definite correlation with your fundus findings and fundus imaging, and wherein useful, corroborate with other imaging modalities, and eventually use your wise judgment to differentiate pathology from an artifact. Now, this list of artifacts is big and huge. I'll be touching upon some common ones and major ones. So I'll start off with certain artifacts which are basically patient and user related artifacts. They may be because the patient is blinking or not focusing at a particular image. You may get a blink artifact or a band artifact. Patient with poor vision, the fixation is an issue, that may cause artifacts. All these situations can be tackled then and there when you're acquiring the image. You can't go back and correct these. So these are those artifacts which have to be taken care of when you're acquiring those images. Your optometrist, or if yourself you are doing it, or the technician, he has to see this artifact and redo the scan immediately. If there is a fixation issue, consider doing a smaller size of a scan. Smaller size of scan happens faster. Patient needs to hold on its fixation for much smaller time. So you may get better, be able to kind of tide over the fixation issues with smaller scan. Also, there may be stretch artifact or duplication artifact. These are all which comes because of inattention or patient's saccadic movements or fixation issues or blinking responses. Even tear film disturbances can also lead to these artifacts. Also, when you're dealing with these artifacts, you have to understand your machine and limitation. If you have multiple machines which you have an option to use, you have to understand which machine gives you a faster scan, which machine takes lesser number of scans. So if you compare, say, an RT-View with a Spectralis versus a Cirrus or a Plex Elite, you'll realize the number of the scan speeds are very different between these machines, ranging from 70,000 scans per second to about 1 lakh scans per second. But at the same time, how dense the scans they are doing, how many more scans are being done by each of those protocols. If you understand your machine, you will be able to tide over these fixation issues and artifacts because of that. Another artifact that you see is what is called as flow signal attenuation artifacts or shadowing artifacts. They are because of something in the plane where the light is coming to the retina, which is getting blocked either by a vitreous opacity, a blood clot, or a pigment clump, which may be in the vitreous or on the surface, which is not allowing flow signal, your OCT light beam or the spectral beam to go through the retinal layers, and you will miss out on important details from those from those data points. You may have decentration artifacts wherein the scan was trying to auto-center itself on the fovea, but it did not go there. And this really becomes important when you're going to do quantitative OCT scans, because if you look at this scan here, the ETDRS grid is being placed somewhere else altogether. So this is a decentration artifact, makes much more, qualitatively you may still be able to interpret it, but when it comes to quantitative octa, it may be an issue when you have a lot of decentration. Another important artifact which really troubled us a lot more in the initial years when we started doing octa was projection artifacts. We have had real struggles where we were not sure whether this white signal we are seeing is actually from which layer, what is causing it. Over a period of time, we have understood how to deal with this. Dr. Gupta also briefly mentioned about it. To understand projection artifact, it is basically a superficial vessel which has some flow there. It is getting reflected onto a deeper layer, and you see the impression of that vessel on a deeper slab. So one of the ways where we kind of encounter or kind of remove this is you go through all your layers slowly, as the video Dr. Gupta was showing. You can move your segmentations down. You see the pattern of vessels as you go from A point to C point. If you look at point B here, you see this V-shaped vessel here, which is actually from the superficial layer getting reflected in the deeper layer. So look at the anatomy of the vessel. This was what we were doing most of the time earlier, till we started using a lot more flow signal and we started switching on flow. So the moment you switch on flow in these OCT angio, so you have two modes. You can either have a flow off or a flow on. The moment you have flow on, you start seeing these red dots appearing as flow signals. Easiest way to interpret an artifact here is if the flow signals are lying right one below the other, they're nothing but projection artifacts happening. So this is a projection artifact from a superficial vessel coming onto the deeper layer, superficial vessel to a deeper layer. But what you see here, where there is no corresponding flow signal on the top, is actually the lesion which you're trying to find. So look for your flow signal, look for whether they are parallel one below the other. If they're one below the other, more often than not, these are projection artifacts. Again, so that was the same photo, just highlighting it here. These are projection artifacts coming up here, while herein, what you see flow here is the lesion which is being picked up here. So as I said, to tackle projection artifact, apart from flow signal, anatomy, also look at NFAS slab analysis, look at the corresponding NFAS photo, and wherever required, you can use other imaging modalities to help you out there. Next is a segmentation artifact. Now, each of the OCT machines have a different way how they segment different layers of the retina. Angioplex will be separating in a different way from spectralis, octa, from SSOCT of a top con. Their definitions of what they call as superficial plexus, deep plexus is totally different. So remember, when you're dealing with different machines for the same patient, each time you do it on a different machine, it's not wise to try and interpret one octa from another based on different machines. It may introduce artifacts on its own. Slab segmentation is an important thing which you have to sit and correct on the machine if there are issues. I'll show you a great example how slab artifacts can disturb us. This is a Angioplex, this is a Zeiss Cirrus 6x6 OCT scan, where you see a segmentation from the superficial plexus showing a network around the foveal avascular zone. When you go to deep plexus, you feel you have looking here at a widened FAZ, but this is not a widened FAZ. Actually, you look at your segmentation, it is passing through an area of void. This is a flow void because there is a neurosensory detachment there. There is no vessel within the detachment. So obviously, you're going to get no signal coming in this area because your segmentation is running right through the center of that SRF pocket. So that's how you have to interpret, go and check where your segmentation is passing from and able to correct that manually. Earlier, the machines didn't allow us to manually change the contour of these segmentation lines. Now we can even play with the contour of these segmentation lines to get better fit on our OCT angiogram. Another example wherein we were trying to look at this particular lesion, which is visible here inside a SRF pocket and PED. This was the initial auto segmentation of ORCC slab which had come from the machine. We went back, sat, took the cross to that particular PED area, properly corrected our segmentation, and we were able to see a large network with a cluster of vessels sitting right at that area. So
importance of doing a good segmentation emphasized here. Another patient who had these multiple nice drusen's on the retina. This is an false color image photograph showing multiple PEDs in both. This is the right eye, superficial and the ORCC complex showing these multiple PEDs, but we could barely pick up some kind of a network forming in ORCC slab here. We went back, did a good segmentation of RP fit. You could really see kind of coiling up of this net under those PED in the right eye in an 8x8 scan. And this is the whole lesion when we did a 6x6 scan, RP fit with a nice polyp flow signal, large BVN network, which we could pick up in this right eye of the patient. Similar one, another proper segmentation could pick up a polyp in the left eye of the same patient. We have a lot talking about wide field OCT angiography. It definitely has its merit. This is a 12x12 montage scan wherein you can really go beyond the normal conventional OCT angiographies that we were earlier looking at. Allows us to look at peripheral retinal vascular abnormalities beautifully. But wider the scan also comes with few demerits. The artifacts get more accentuated. All the artifacts which can happen in a smaller size scan happen much more in an wide field octa because of longer image acquisition time. There is something called as peripheral defocus. As you go more periphery, the retina kind of warps. It's no longer flat, so it has a curvature to it. So there's a defocus element which comes to it as you are going more peripheral. If your wide field is very sensitive to slightest of misalignment between the OCT beam and pupil, and what we get alignment error when we try to montage these images, we'll show in the next slide. Also, this particular study, which analyzed about 7,500 wide field scans, it said that sometimes in these peripheral OCT, we have to be very careful because the weak signal strength coming from periphery can actually mimic a non-perfusion area also. So look at this particular OCT scan. If you look at the montage here, what you are seeing here is alignment artifact. The vessels are not really aligning well with each other. These are the alignment artifacts that you can see. Also what you see, these are real non-perfusion area, but what you may be seeing here in this area, these are not real non-perfusion areas. These are also because of the wider field that you are able to interpret it. So to summarize, OCT angiography as a tool is added a lot to our armamentarium. We are learning a lot from this tool. NFAS visualization along with B-scan, proper layer by layer analysis is its strength. You can really see different vasculatures, but artifact is its weakness or its tantrums. You need to understand these tantrums. You understand these artifacts, you overcome them, take time with your machine. You are definitely going to get a lot more answers from your OCT angiography. Thank you.
Thank you, Ritesh, for your wonderful presentation. What we have learned from Ritesh's talk is how to interpret artifacts. And these are very important. If you see lines on your structural images, that means Puneet will go with Puneet. We'll go with Dr. Lalit Verma because the lines what you see on your structural images that denotes that there is a saccadic movement. Either the patient fixation is not good and you are not getting a good images. Many times you have to change from an wired, if the patient fixation is not good, go for a smaller slab size where you will not get much of motion artifacts. Primarily with the projection artifact, which was a problem initially, but if you do a manual segmentation and if you sit on the machine and do a manual segmentation, I can tell you, you will, OCT is, reports are not to be interpreted with one picture. So go ahead, if you have a doubt, go ahead and sit on the machine, do a manual segmentation, and I can tell you, you will get wealth of information. You will learn many things about the pathology of the disease, where the disease, and you will definitely come to a diagnosis. With this, I'd like to introduce Dr. Lalit Verma. I said Octa has still not replaced fluorescein angiography. So he will be talking about fluorescein, whether Octa can replace fluorescein angiography. And since Dr. Lalit Verma has organized such a wonderful, I will like to congratulate him for organizing such a wonderful conference and giving us a platform where we can interact. Thank you, sir. And yes, sir, you can ask one last question, then we'll proceed.
Yeah, sir, all depends on, yeah. So as I said, OCT angiography reading from printouts is a very fraught with lot of errors. So if you want to really interpret OCT angiography, you need to sit on the machine and do. No matter how much good a printout or quality of paper or resolution you may use, you will never be able to. You can get good printouts, but then first somebody has to be on the machine to get the scan at the right place, at the right segmentation. And if you print that out, you will get a good. But if you go by standard segmentations which either a Zeiss or a Heidelberg is giving, each of them, like Heidelberg gives 4 standard slabs, Zeiss gives about 8 standard slabs. So if you go by them only, you may not be able to interpret it with that much surety.
The most devastating artifacts and problem I find with myopia.
Yeah.
And remarkable and uncorrectable artifacts.
That's because, ma'am, because the myopia, as we know, the posterior staphyloma, the moment the retina is no longer flat a surface, all our projection, all our artifacts can kind of enhance too much.
I am deadly in need of OCT angio because if there is a Fuchs hemorrhage or Fuchs spot, I want to be that sure that there is no underlying lesion. But usually we fail to do
The trick, I mean, the only way out is a small trick is to use the smallest possible OCT angio slab, like a field. Use a 3x3 scan because in that area you may have a little flatter retina. The bigger the scan you use, the more curvature of the retina comes into play.
usually I use 4x4. I stop
Yeah.
But if it is a flat
I think
retina,
myopic
then
patients-
if a myopic CNVM, yeah, I also use it very frequently because
my-
that is one place where, follow-up as well as indication for retreatment, it shows a very good regression, provided there's no staphyloma and,
Yeah.
this thing.
If,
Okay,
if
yeah.
you are doing myopic angiography, one simple tip is use a very small scan size, and you can also do an angiogram with the patient's spectacles put on.
Usually if the patient is wearing contact
Corrective
lens,
glass.
I do
Yeah.
contact lens.
Yes.
Or to change to the minus lens.
Power adjust.
Or better, I usually
Yeah.
do with the contact lenses. Yes, you are totally right.
Okay, thank you, Avninder, for this repeated course and a very important subject and evolving subject. A lot of us may not be having Octa machine, and a lot of us are learning also because every time, and it's a machine where if you, like Avninder was saying, that you have to sit there, unlike angiography, you have to sit there, you have to spend a lot of time. And you can't just be dependent on technician, usne kar diya and you interpret it. So, welcome to this very nice venue. You see, today imaging modalities are so many, and without us having recourse to these imaging modalities, we sometimes cannot pinpoint diagnosis. So I get sometimes scared that what were we doing when we did not have all these things. Most of the, I'm talking of a couple of decades back when we hardly had so many imaging modalities. So today it's the era of multimodal imaging modality, and I still believe that my FA machine is still alive, it is not dead, that we still use invasive angiography, which has been the gold standard for a long, long time. This FFA, although Octa also, wide field has come up in a big way, but FFA, very nice pictures, very impressive pictures where you can tell the patient and counseling. Long experience, decades and decades maybe experience, plus it is cheaper and like Ritesh was telling about so many artifacts, so there are not much artifacts in these once you are doing invasive angiography. And although CNP areas can be very, very nicely picked up in all the pathology in Octa, but leakage is one part, although you see now functional or flow indices have been described where you can, even on Octa, you can comment upon this. But to be very sure, especially in polyps and other things, we still sometimes recourse to invasive angiography, whether it's FA or ICG. The disadvantage quoted by on angiography is considered invasive. Even one occasional death has also occurred in such invasion. And it takes some time, 5 to 15 minutes of imaging, less resolution. So this chart I had compiled a long time back where FFA and Octa were slightly compared. FFA wider, Octa also wider, 12 by 12s are available. Safety, Octa is non-invasive, can be repeated SOS whenever you want. No contraindications. Resolution is higher. And level of imaging, as was being told, you can have superficiality. Wherever you want to study vasculature, you can have segmentation of that level and do it. FFA scores that it's a more dynamic procedure. Motion artifacts and other things are less affected. It's relatively cheaper. But more the number of machines, the cost comes down. And experience-wise, I think older generation has more experience with FA. So conditions where FFA, I feel, have an edge of Octa, and that's what I stand here for, to defend FA, is peripheral lesions like these, something like Eales disease, which is common in our country, peripheral vasculitis. So they can, in a short, picked up without being any discrepancy. Leakage, again, which is sign of activity, very nice pictures you can have these. And this does add value to your decision making also. In Octa, sometimes decision making becomes very tough, whether I should or should not. There may be sometimes CNVM, which are quiescent CNVM, so a lot of people, we should not be treating that. And dynamic property of leakage is unique to FFA and ICG. You see, to say that CNVM has gone, I think, although you can indicate on Octa, but I would still prefer that leakage is not there. Like you see this patient, long time back done, now you see how there's hardly any leakage. Ultra wide field is a reality. I think a lot of you have these machines, Octos and other, where you can, view as long as 200 degree also. Artifacts is one thing which I am disturbed about, which are a negative point about Octa and is not there in FFA. Things like poor visual acuity, limited fixation, not much of a drawback on FFA, but you have to take time in an Octa machine. Decision making about laser. I think laser I will never do without a FA, because I have to have the leakage areas. The decision making in any disease, whether it is a vascular block or diabetes, CSR, Coats disease, angiomas, I will never depend only on Octa and start lasering these patients. Maybe a lot of young people may do, but I would not advocate also that these diseases, wherever you are doing a focal laser. PRP is a different ballgame. PRP you can, but for focal laser you need the site of leakage and various phases of angiography so that you can do precise, small amount of laser. Then FFA, things like VKH and these things can more easily be done on FA rather than Octa. So I know future is weighed towards more Octa, and is gradually people are sitting on Octa machines rather than FA. But still FA, we have not covered FA and don't do it, but in our center also the role of FA has decreased quite a bit. People are more dependent on OCT and Octa, which may be in the single machine also, so that we can minimize the invasive part. Earlier it was primarily a diagnostic tool, but now a lot of decision making also can be done. You see, previously ICG was a must for diagnosis of IPCV, but no longer. Now you can diagnose with reasonable amount of certainty. If not 100%, near to 100%, you can diagnose on OCT and Octa. So whether FFA should be condemned and put to dustbin, I still would debate that it still has a role in all that multimodal imaging modalities which I said. Thank you very much for having me.
Thank you, sir. We can have two questions from Dr. Lalit Verma. Meanwhile, I'll request Dr. Puneet Gupta to get ready with his presentation. He'll be talking about OCTA in age-related macular degeneration. And actually, OCTA in age-related, now I don't do any fluorescein angiography in AMD patients. I only go in for an OCTA for my follow-up and diagnosis. Dr. Puneet Gupta is director at Sharnam Eye Center. And I know Puneet from last 20 years, and he's one of the persons who has latest technology, and it's great to have a latest technology. You have latest technology in institution, but to have latest technology in a private practice, I always admire him. He has only one of the best OCT angio machines, endoscopic surgeries. To have all this in practice, I bow down to him for his academic skills and better care for the patient. Any questions from Dr. Lalit Verma?
Can I add a comment for Lalit sir's talk? I think, sir, in spite of OCT angiography jumping leaps and bounds, I still feel wherever we are stuck in a doubt, we always fall back to the gold standard of dye-based angiography, whether it is fluorescein or ICG. A lot of cases I know OCT angio can pick up things, diagnose, but when we are stuck with a dilemma, it's FA and ICG, because this is the only one which is actually showing us the vascular dynamic flow, and it can pick up things like leakage, which nowhere an OCT angio can help. So I still feel it is nowhere gone. It is going to be there for a lot more time. I don't think we are going to be replacing dye-based angio that easily.
Very rightly said, you see, because Avinder gave a topic where, it was, I had to defend that, and I told also, it's a dynamic procedure, and nobody will think that FA is condemned. FA still has a relevant role, and like it's a dynamic, and within 5 minutes you have such wealth of information, which, you may have to take minutes or hours to sit on that.
So you may do OCT quickly, OCT angio, but you take more time to interpret. FA you take a little more time to do, but you interpret very quickly.
And inflammatory diseases like uveitis on all these things, there's no replacement of fluorescein angiography.
Our session the day before, fluorescein is the window for medical record. But I think if you are in dilemma, for example, CMV, I will go for the B-scan. I will ignore totally the OCT angio because it's according to, of course, as you know, the flow or the blood flow, we can get the CMV or not. So I go automatically for the B-scan and I recommend.
And there we come as a role of what we call as a multimodal imaging. So everything we have to do to come to a diagnosis. Yes, Puneet.
Thank you, Abninder, for the kind introduction and giving me this opportunity to speak on OCT angiography, its pattern to evaluate AMD and its progression. In my opinion, macular degeneration is one retinal disorder where the potential of OCT angiography technology is best utilized and gives practical clinical information which is translated into its clinical use. One basic information which is important in interpreting OCT angiography in relation to macular degeneration is that to generate an image on OCT angiography, there has to be a minimal amount of flow within the vessels. If there is no flow, there will not be any image. And another important thing is that OCT angiography cannot directly show leakage. On the left-hand side, there are cross-sections of the retinal images, and on the other side, you see these are various layers and fast maps. In macular degeneration, we have to concentrate mostly in this area of the scan. That is the avascular complex. Above that is the superficial and the deep vascular complex. And this is the area of avascular complex, choriocapillaris, Brooks membrane, and the choroidal vessels, where most of the activity occurs in age-related macular degeneration. Though there are situations like RAP and other things where changes can occur. But to simplify things, OCT angiography has high diagnostic value in detecting macular neovascularization or choroidal neovascularization. It is useful in detecting all three types of macular neovascularization, whether it is type 1, type 2, or type 3. Another important thing about this is you can differentiate these types of neovascularization very effectively with OCT angiography. In macular degeneration patients, the retinal architecture is very much disturbed, so you have to sit on the machine and do your analysis using these segmentation slabs by your own. You cannot depend on any other person, whether it is a technician or any other ophthalmologist, to decide what is happening inside the machine. And another thing is reviewing both the NFAS and the B-scan images are important to reach at the right diagnosis. So you have to compare both these B scans. You have to see the flow signals on the B scan and interpret those images with the corresponding NFAS images. The segmentation should be correct to locate the choroidal neovascularization. If your segmentation lines are not passing to the right planes, then you may detect the false choroidal neovascularization, and your interpretation will be wrong. Now, this is a patient where you can see this. There is these yellow dots. This is the Heidelberg images, and you can see these yellow dots are showing that the flow is present in this area. These are this is the image without any OCT details. Here you can see only the flow, and here these flow dots are superimposed on the B scan. And this is the flow present below the RP, and this is the NFAS image of the same. This is type 2, where you can see this flow is present above the RP, and this is the vascular network above the RP. There can be mixed or combined type of lesions also. OCT angiography can detect polypoidal lesions also. You can find flow at the tip of the thumb-like PED here, and also a double layer sign which shows that there is a branching vascular network. And these two things indicate that there is a possibility of presence of polypoidal lesions, polypoidal choroidopathy. Generally, it is difficult to pick on OCT angiography. Why? Because the flow in the polyps is less, and it is difficult to pick lower flow lesions on OCT angiography. But if you combine the NFAS and the B scan images with flow overlay, you can detect many of these polypoidal lesions also. Although ICG angiography is the gold standard for these lesions. This is an interesting patient, 60-year-old lady with 6/9 and 6/9 partial vision in the left eye. There was no flow. This lesion at the macula started showing some hyporeflective spaces, and the vision also started deteriorating, and it became 6/36 with subsequent visits. Considering this as a serous fluid, this patient was given anti-VEGF injection, but there was no improvement in vision or in the presence of fluid. OCT angiography revealed that there was no flow, there was no choroidal neovascularization. Actually, this was a patient of adult onset vitelliform dystrophy. So OCT angiography is also a reliable tool in confirming the absence of neovascularization in such situations. Similarly, this patient also had this fluid present, but there was no neovascularization. It was actually a patient of chronic CSR, long-standing CSR. This is a patient with flow present here, and you can see this on the NFAS image also, but there is no fluid present. So this is a patient of non-exudative choroidal neovascular membrane, quiescent choroidal neovascular membrane. Almost about 20 to 80% patients eventually convert to exudative CNVM from these patients. So these patients need close follow-up, but mostly you don't require to treat these patients until you see signs of fluid development. These lesions can only be detected effectively on OCT angiography, and they are easily missed on fluorescein angiography as well as on OCT. Fellow eye examination is also important in macular degeneration patients. 6 to 20% of the exudative macular degeneration patients have non-exudative CNVM in fellow eyes. And these patients may develop exudation at a later date. Now, how do you differentiate between active and non-active macular neovascularizations? There are features like if the network is densely packed net, C-fans with extensive branching, extensive capillary sprouting, and numerous anastomoses, and also if there is a dark halo around the choroidal neovascularization, all these signs are indicates that this is an active neovascularization, and this might require treatment. Larger diameter filamentous vessels with lesser branchings, lower capillary sprouting, and anastomosis, and these are the lesions with inactive lesions. Now, treatment response can also be monitored seeing the appearance of neovascularizations with the help of OCT angiography. Most of the lesions, the maximum response occurs 2 weeks after the treatment, but the reproliferation with reopening of the previously closed choroidal neovascularization can be noted by 4 weeks. So you can monitor these lesions by seeing the appearance of neovascularization, how it is responding. Now, what suggests activity on OCT angiography? Increase in the lesion size or flow area, increase in the vessel density, high flow signet density. These things, there are softwares in different machines, some machines, which can measure these areas, flow areas, vessel density, and signet, and give you information whether the macular neovascularization is active or not. The peripheral anastomosis or loops, the morphological lesions, can also give you an indication. The dark halo around the lesions, all these things indicate that there is a possibility of activity of choroidal neovascularization. There are limitations of OCT angiography. In most of the machines, the area scanned is too small. There are various artifacts, segmentation errors, and it does not show leakage directly. But in spite of that, it has high diagnostic value in detecting the presence or absence of macular neovascularization. It has capability of detecting early and subclinical changes, and it is a useful and dependable tool in monitoring and managing your neovascular AMD patients. AI-based OCT angiography analysis is under development, and that will, in very near future, will help in deciding which patients needs treatment. Thank you.
Thank you, Puneet. Meanwhile, I'll ask Dr. Anand Rajendran. We are lucky to have one of the most accomplished speaker, Dr. Anand Rajendran, who heads the Department of Retina Vitreous at Arvind, Chennai. He's a wonderful speaker, and he'll be talking about role of Octa in diabetic retinopathy. Any questions from the audience to Dr. Puneet Gupta? Actually, he has demonstrated, with OCT angio in AMD, one thing is there, ki diagnosis will be there. Second thing, now we are looking at various vascular patterns, how they are proliferating and how they are regressing. And on these features, we can tell whether the patient is responding to your anti-VEGF treatment or will need treatment. And another very important point, what Dr. Puneet Gupta has highlighted, is about non-exudative AMD. I think non-exudative AMD you can only diagnose with Octa, you cannot diagnose with B-scan. So this is one blessing what we have got with Octa. Patient comes with 6/6 vision, nothing is there on OCT, and you find a good CNV membrane, and you need to tell these patients, yes, you have to come every 2 months for your review. Dr. Anand Rajendran, please.
Yeah, thank you. At the outset, I'd like to thank Dr. Abnindra for putting up this wonderful IC, and I think it adds great value to this conference. So it's my pleasure to talk to you about macular as well as wide field Octa in diabetic retinopathy. So the role of Octa in DR, it's demonstrated, primarily demonstrates retinal microvascular changes, be it structure or morphological alterations like microaneurysms, tortuous dilatation, irmas, NVs, and collaterals. It also highlights structural loss in the center, showing up capillary non-perfusion, and therefore, as we talked about earlier in discussion, macular ischemia and enlarging FAZs, and in the periphery also, and through structural density metrics such as perifoveal capillary density. This translated clinical value is also showing all these changes from the preclinical diabetic retinopathy stage to the proliferative stage through all these anatomical issues, and also highlighting and giving us an ability to objectively evaluate diabetic macular ischemia. It also is now increasingly helping us correlate diabetic macular edema and anti-VEGF response, and we'll see in a bit how. Also highlights peripheral changes as we are enhancing our ability with wide field OCTA, correlating retinal capillary non-perfusion and diabetic retinopathy stage, as well as looking at and understanding evolution and regression of IRMAs and NV. So this is how we'll go about. So the matchup, FFA versus OCTA, Dr. Lalit's talk just now kind of highlighted all that, but understand that the FAZ on FFA correlates very well to the OCTA superficial vascular plexus FAZ. Okay, so these are very comparable. But understand also that the FAZ on the deep vascular plexus can only be studied on OCTA. You can never see that on the fluorescein angiography. So this is something also to understand. The FAZ in the superficial vascular plexus and the deep vascular plexus may be differently sized. And so it's OCTA is the only one which gives you this capacity to look at that. All right, so looking at OCTA FAZ in clinical DR, early changes and stages. So like I mentioned earlier, preclinical diabetic retinopathy, OCTA is the only one which can really give you early sighters, okay? Be it the disruption in the FAZ at the superficial capillary plexus, as you can see, or focal microaneurysms that you can pick up in the DCP, which can correspond to focal capillary non-perfusions in the choriocapillaris. So if you have a diabetic patient who's coming in and you get an OCTA and you pick this up, you can tell the patient that you're probably hurtling more towards a manifest diabetic retinopathy if these changes are there. Now, OCTA FAZ and the diabetic retinopathy changes. Now, Kim et al. Did a very elegant study and just showed us, one of the first to show us, that increasing FAZ dysmorphia and diabetic macular ischemia definitely happens as you progress with the diabetic retinopathy stages. As you can see from the healthy to PDR, that FAZ is continuously increasing. So not just is a manifest retinopathy increasing, but also is there is a slight push towards ischemia. And Alam went forwards and quantitated these OCT analysis and helped computed identification and staging of DR. Now looking at OCTA FAZ and diabetic macular edema and prognosticating of anti-VEGF response. Now Lee did a very nice study with OCTA DME and its association with anti-VEGF response. They looked at 51 poor responders, 32 were good responders, and they found that in the poor responders there was significant damage to the deep capillary plexus, not quite always superficial capillary plexus, and the marker for poor response to anti-VEGF is DCP loss right at the outside, at the baseline, and the corresponding OPL, outer plexiform layer disruption. So I'll just show you a few examples. An example of a good responder where there was lesser distortion of the DCP, more microaneurysms, again we talked about this earlier, is seen on deep capillary plexus than can be appreciated on fluorescein angiography. A poor responder, on the other hand, had a greater distortion of DCPs, and you can see the microaneurysms again being seen better on the DCP in the right panel than fluorescein angiography. Okay, so this is just some examples from our experience. You can see DME with a good response, good resolution with anti-VEGF treatment. Some as superficial capillary plexus loss, DCP loss also. But you see a case with a poor response, where it was fairly refractory to anti-VEGF. Initially, SCP loss was there, but you can see that the deep capillary plexus loss at baseline is far more. So if you when you're treating your patients, like I said, if you can get an OCTA done and you find at the start macular edema with a significant deep capillary plexus loss, that should ring alarm bells and tell you that perhaps this patient may not respond very well. Perhaps you may even think of moving straight away with a stronger anti-VEGF. So these are considerations that you can keep in the back of mind. Now, OCTA FAZ and diabetic macular ischemia. So this study by Rosen showed that, like in Kim's study, the FAZ increases as you go down, as you increase and become more severe with your diabetic retinopathy, but also it is the perifoveal capillary density which is also dropping off. Look at that map on the right panel. That red signature is continuously decreasing. It's becoming more yellow. That means vessels, not just in the phase is increasing, but around the phase also the vessel capillaries are dropping off in intensity. Now, Bradley did a nice study looking at evaluation of diabetic macular ischemia using OCTA, 24 patients. This was the definition of DMI. And they looked at they looked at FFA versus OCTA and looked at the three layers that we talked about, SCP, deep capillary plexus, choriocapillaries, and brought out a very nice grading system, very intuitive grading system, which they evaluated for reliability and consistency. So this was what they did. I won't go into all the ways. The FFA and SCP were looked at together. They had these 6 grades: absent, questionable, mild, moderate, severe, ungradable. In the mild versus moderate, it was phase outline disruption less than half original circumference or more. The DCP, they made it into a 4-quadrant grid. Again, these 5 grades, and mild to moderate and severe phase outline disruption less than equal to 2 quadrants or phase more than 2. And the choriocapillaris lay, again, they did a 4-quadrant. It was a plus or minus, dark defects plus, loss of HR homogeneity, and minus. So just an example from there where they found FFA here, for example, DMI. Okay, less than half phase, and DMI less than half. So this was just an example where they show here the DCP, there was a 2-quadrant phase disruption, mild to moderate DMI, choriocapillaris, dark defects with DMI is present. The key findings is degree of DMI was reliably assessed by OCTA SCP, and there was moderate agreement between DMI grading results for OCTA SCP and FA. And most important thing is far more integrator agreement with OCTA than for FFA. Okay, now wide field OCTA, the enhanced implication for PDR. Handan showed that OCTA phase dysmorphia and DMI correlated very well with increasing peripheral capillary non-perfusion. And just a few examples to wind up. Wide field fluorescent angiography here, an example, you see retinal thinning there. And like we talked about the different scans, you can see it in the 3x3. But as you go further, you are seeing more and more of the retinal thinning correlating very well to the ischemia in the periphery also. Another example where you find that thickness seen initially in the 3x3, but also very well in the larger maps. And you see the this non-perfusion, and when you go from the superficial flow to the vitreoretinal flow, you see small area of neovascularization also being highlighted here. And when you do the OCTA, wide field OCTA, you see that corresponds very well to a little tuft popping up above the ILM, which tells you that this is correlating, this is a new vessel, and you can see that here also. So this shows you, also we talked about flow overlay B-scan. You see this high magnification SS OCTA shows an IRMA evolving into a new vessel. You see as that flow overlay becomes more intense and surfaces towards ILM, you will see it popping up, breaking through the ILM. That's when it becomes a new vessel. And this is also showing the evolution of the NV captured, as you can see from baseline. That flow map signature is going up, getting more intense through baseline through 1 month, and then breaking through at 3 months, and you can see a full-blown NV there. So that's also a way. So IRMA can evolve into retinal neovascular lesions, as the Rosenfeld group showed us, can directly evolve. Wide field SS OCTA can early detect, and you can frequently monitor IRMAs and NVs. And in summary, using the same field of view, wide field swept OCTA was quite similar to ultra wide field fluorescent angiography, and changes were well seen on wide field swept OCTA, and or IRMAs, NVs, and areas of retinal neoperfusion can be identified on SS OCTA. So in conclusion, diabetic retinopathy stages, I'll just put everything together. Increased phase dysmorphia, diabetic macular ischemia can be seen with progression in DR stages. DME grades, there's increased DME severity, phase area, foveal thickness correspond well with worsening acuity. Anti-VEGF response, DME. Poor response, let me reiterate, the significant damage to DCP, not quite SCP at baseline, and therefore you can use that as a poor marker for poor response. Degree of diabetic macular ischemia can be reliably assessed better by OCTA on the superficial capillary plexus, and there is far better intergrader agreement. That is, you have multiple OCTAs, you will have the better agreement than with FFA. Peripheral capillary non-perfusion, the OCTA phase dysmorphia can correlate to your peripheral capillary non-perfusion also. And in summary, finally, wide field OCTA has the potential to replace color fundus imaging and FFA as a potential gold standard later. Thank you.
And thank you, Anand, for your elucid presentation. Now, I'd like to invite a young dynamic speaker of the session, Dr. Ajay Purohit, who has climbed up the ladder of academics very fast because of his interest in academics. He's director at Ratan Jyoti Eye Center, Jodhpur, and Center for Sight, Jodhpur.
I
We'll
have a
have
question.
discussions about these two vascular disease, one with diabetic retinopathy and retinal vascular disease, vein occlusion, after his talk.
Thank you. Thank you, Arvind, sir, for this opportunity. Because of the time, I'll just go through the slides and then we can have a discussion later. So I'll be discussing and showing cases about the vascular disorders of branch vein, CRVO and CRAO, and a slide for glaucoma part also. So Octa, in my practice for BRV, I use it very commonly because it demarcates the territory involved. Macular ischemia, it already been discussed, and neovascular patches, which is very clearly seen on Octa. And with NFAS image, you can see the demarcation of ischemic and non-ischemic retina in the superficial and deeper layer. And when we're planning laser also, no, these octas, 8 by 8 or 12 by 12 octas can guide you and actually give a proper demarcation where to the laser, up to what extent to laser. So I'll show you this case. This is a superior temporal BRVO. Let's see. Pointer or something. Okay. So this is the small NVE patches which are there, and these are the non. Okay. Thank you.
ये नहीं आ रहा कुछ यहाँ पे, स्क्रीन बंद हो गई है.
सारे स्क्रीन
Yeah, thank you. So these are the neovascular patch, small neovascular tufts which are there, and these are the massive multiple areas of non-perfusion which you see in superior temporal BRVO. This is another case in 74-year-old hypertensive, which came with a history of scotoma in the right eye and a decreased vision in the left eye since 1 year. So in the right eye, when we did an Octa, there was a small vein occlusion which was there. But what interesting was in the left eye, and there was this macular ischemia which was there. So we did an 8 by 8 Octa, and you see this massive temporal non-vascular area which was there, non-perfused area which was there. And sectoral laser was planned in this patient. Another case, inferior temporal BRVO, this is a 6 by 6 image. You see that inferiorly there are huge areas of capillary non-perfusion areas. And the macular ischemia is not that much. The patient didn't really have any symptoms. She just came for a routine checkup. We saw the BRVO and just asked her for the doctor. And she was advised a PRP, sectoral PRP. Another, this is a long-term follow-up patient, and she's a 60-year-old female with no significant disease, just diminution visions in left eye. She had a history of floaters for which she came to us. And when you scanned her, you see the inferior temporal non-perfused area which was there. These are the areas of collateral which developed. And you see this area which was seen as a void, but when you saw the on-first image, the VRI interface showed a tuft, NVE tuft which was there. And again, the superficial and deep, you see this area is a completely vascular area, and this is the inferiorly non-perfused area which you can see, clearly demarcate on an NFAS image, the deeper layers. Again, the same macular ischemia is there, and these are the collateral vessels which developed. On follow-up, she was being treated, and we have a long-term follow-up with this patient, and she was treated with the NV anti-VEGF and PRP, and after 2 years, she again presented to us with a huge NVE. You see the progression, which a small NVE patch has converted to a larger NVE patch, and these are the artifacts because of the vitreous hemorrhage, because of what she presented to us. Again, after 3 years of follow-up, these neovascular patches, they again kept on growing. She used to come only to us when she had floaters, and she used to get injections, she would get PRP, and she used to disappear. So every time she came up, the neovascular patches, they kept on growing. And this is the beauty of Octa. We can actually monitor these changes in due course of time. Again, anti-VEGF was given, and you see the degradation of these NV patches post-NV anti-VEGF. The huge NV here has regressed here. these patches they actually regress. So you can see the progression of disease. You can counsel the patient that your treatment is actually working, and this is how the regression is actually going on. And you see the on-fast image. This is on presentation, and you see this band. This is a formation of epiretinal membrane and or the traction band, which has happened in 3 years of the disease. I'll show you a case of CRVO also. This is a 43-year-old male with history of trabeculotomy in the other eye. The pressures are normal. He presented to the decreased vision, and this was CRVO which was there. And on resolution of hemorrhages, we did an 8x8 octa. You see only the central area is perfused, because of which he is maintaining a 636 vision. Rest the complete peripheral area is non-perfused. So we planned early PRP, and this, you can see the PRP was done. And in follow-up, the patient is responding well. He hasn't developed any neovascular glaucoma and still preserving a good ambulatory vision. Now, this is a very I don't know, maybe a rare thing which you see in our clinical practice PAM, or mostly it is missed sometimes because it's a more of OCT diagnosis. How Octa is helping us with this, because when you see a PAM, we see these whitish areas. These are the areas where the capillary non-perfusion are there. And we see in OCT also, these are hyperreflective bands which you see. This is the beauty of the NFAS image on the OCT angio, which has helped us to really differentiate a PAM. Again, the PAM, the deeper layers are more affected rather than the superficial layers. And only on Octa we can see the deeper layers this clearly. In cases of CRAO also I'm doing Octas, and this is it's a 69-year-old male who presented to us with a sudden diminution of vision. And on the left eye we diagnosed him to have a CRAO. When you perform an Octa, this is the right eye Octa, you see the peripapillary capillaries are completely fine, highly dense peripapillary capillaries, but you see the left eye, the peripapillary capillaries are hardly visible, maybe due to edema also, but the peripapillary area is the area which is highly non-vascular. He developed a MI 7 days after the CRO, and when he came back after a month, you see, again, the peripapillary area, you see the vascular density in the normal right eye, and the peripapillary density which is markedly reduced in the CRO eye, even after recapitalization of the vessels. So even this follow-up also, we can see how capillary perfusion is taking place in these CRO patients. Now, one of the uses in Octa in glaucoma is when you see a wedge-shaped defect. So this is the Octa of a glaucomatous eye. Without any wedge-shaped defect, the peripapillary capillaries are very well, there is good density of peripapillary area. But when you see a wedge-shaped defect, which is a diagnostic of glaucoma, and wedge-shaped defects are actually the areas of decreased vascularization. So in on-fast image, we can see this wedge-shaped defect clearly, and you see when you did an ONH Octa, the wedge-shaped defect correspond to a decreased capillary flow. And after, this is a follow-up patient after 3 years, you see the wedge-shaped defect is actually growing, widening. So the patient is progressing over glaucoma with a very well-controlled IOP, still the patient is having a glaucoma progression. So even glaucoma in patients with wedge-shaped defect, we can monitor these patients, we can actually see, even with well-controlled IOP, these patients, they really progress sometimes. Thank you.
Thank you, Ajay. Two questions, like you showed wedge-shaped defect on your OCT ONH images. Now, there are different slabs of OCT images. So, which slab you take it for the diagnosis?
This is the superficial slab which I usually take for the wedge-shaped defects.
Anand, I have one question from you. You very rightly elucidated that only diagnostic modality which can distinguish between superficial and deep capillary plexus. And you said deep capillary plexus ischemia tends, if we are able to diagnose, how will you quantify whether the vision is less because of the superficial loss or deep loss? So how will you differentiate and what measures we have to take in these kind of patients?
So ultimately, everything is a continuum, because all these layers, the entire visual neuronal pathway is going right through all the layers down. It's just that the vascular supply to these neuronal elements is affected. But the correlation with your outcome with, either it is anatomical or structural with anti-VEGF response seemed to correlate with these, although you could say the sample size was not a huge amount, it was not like 500 cases, it was just a small number, seemed to correlate better with a deep capillary plexus. And this has hitherto never really been studied or even recognized, that when we talk about FAZs traditionally and as well as with, the initial octas which we had, we were always looking at the superficial capillaries. We never really looked that deep. So this is now showing us that that correlation to poor responders seems to have a better bearing with a deep capillary plexus. So the association is there. Probably that needs to be borne out with a larger study.
And if you see the superficial plexus is smaller and the deep plexus, if you see in a normal angiogram, is slightly larger.
Yes, yes.
So, and do you have any diagnostic
You mean
criteria?
a
It should
cutoff,
be
a cutoff kind of? No, yeah, that hasn't really been, looked at, from a cutoff point of view as to whether, if something is this much, then these patients go really bad. I don't think so. I think, and that is also what we've also seen is very variable. So in the same patient, they may have two different, they may not, absolutely be the same. And so that has also been seen, by the way, with SCP also. So there is a lot of variability there. We know that the FAZ not in our human population itself is widely variable. It's a big, there's a wide variation. So that is also an issue.
The take home is that it should be regular.
It should be reasonably regular, but if it is excessively massive, then you know that it's possibly because of.
Any comments?
Yeah, so if I can put it in what Dr. Anand is saying is, it is not about one point of DCP, it is more of a continuum over a period of time. You see the change happening in the DCP FAZ, and that is what correlates more. As of now, we don't have that one level of cutoff as we have for FAZ on FFA or 350 micron or 500 micron. It is more of how it is progressing over a period of time, how the DCP FAZ is enlarging, that is more correlated.
Yeah, but also just to further clarify, a very large loss of DCP is like what he was. We agree that the progression is important, but also fairly large thing. But that has a fixed number hasn't been set for that. To answer your question,
I have a question from Anand. Are we using these preclinical diagnostic criteria like vascular density and FAZ in regular clinical practice to detect these changes?
No, absolutely not. Because even as we've all discussed, that a lot of us need to go back after the patient's we get that information, look back and do a lot of segmentation and stuff to understand the octas better. It's not something that comes in immediately. But please understand, today we are increasingly going towards AI, and I think different speakers have spoken about AI, touched upon that little bit, and there are new AI algorithms coming. So we are not very far away from a day when an octa is acquired, put towards like a diagnostic AI system, and people pick up that. Today, we are talking about proteomics, where a blood test can tell you what your 5-year risk of getting a diabetic retinopathy. Tomorrow, just standing in a kiosk in a mall, somebody can just get a snap, OCT, octa, everything worked up together, and the AI diagnostic will say that there's a chance of you getting it based on these preclinical.
It's a question.
Yeah. Yes, sir.
Please come.
When there is diabetic macular edema, like you are seeing a distorted DCP, so the edema itself can cause the artifact. So I tried to look for this particular point, but I could not get a satisfactory answer how to account for this distortion caused by the edema in the DCP. Because most of the times we keep saying that DCP is the first one to get affected. But if you look at the cases where there is no edema, you don't see that much of a difference between SCP and DCP. So how to account for that when you have edema? Yeah,
this is where also we touched upon earlier. Manually segmenting, that is very important. Moment the edema sets in and there's a lot of distortion, especially when you have a lot of intraretinal fluid, causing a lot of sideways lateral distortion, it's not easy. But at the same time, it's been seen. So it's been borne by certain, this literature, which shows that when it's beyond a particular, excessively, let's say 2 standard deviations beyond what it should be, then your outcome may be a little poorer.
Because there are some certain clinicians who are showing after the edema subside, the DCP has improved. Okay. But it is actually the edema.
Yeah, it's actually the anatomy bringing it together.
Yes.
True. We agree. Yeah.
In this condition, I will omit the OCTA and I will go for the D-scan again. For the biomarkers
Overlay.
I mentioned early in the session, the biomarkers, this organization, the drill sign,
the small cystic spaces that we see in the inner retinal layer, this correlates to the ischemic changes. If it's fine, so it's associated, this edema is associated as well with the mixed maculopathy of ischemia.
No, no, absolutely. We agree that structural biomarkers
Yes,
are there.
the
He's
structural,
looking at, he's talking about the angiographic biomarker.
One important thing is ki in AION also OCTA plays a very important role. And now with anti-ischemic optic neuropathy, I'm not doing any kind of fluorescein angiography. I'm diagnosing my patient on OCTA. With this, I'll ask Dr. Ritesh to conclude the session.
So we come to the end of this wonderful IC. We have been doing this course on OCT angiography for last 3 years now, and each year we learn a lot more and we feel enthusiastic to come back. As we are concluding this session, we are already planning for what we can improve in the course next year on. So thank you all of you for coming here and encouraging us. I hope you take away some good take-homes. I would like to thank our chairman for conducting this course every year and all the speakers who are a part of this course. Thank you so much.